Let's talk about AV nodal re-entry tachycardia and AV re-entry tachycardia, also known as AVNRT and AVRT. Also, don't hate me because I'm an artist. So AVRT and AVNRT are re-entry tachycardias, and any re-entry tachycardia are caused by electrical signals that loop back on themselves. In order to understand what's going on during these dysrhythmias, you've got to understand the electrical conduction of the heart. So electrical impulses originate in the SA node. They then travel to the atria, causing the atria to contract. The electrical impulse is then delayed a bit before it hits the AV node, or the atrioventricular node. It then travels down through the bundle of His, down to the Purkinje fibers, up through the left and right ventricles, causing the ventricles to contract. Now, the only place that an electrical impulse can travel from the atria to the ventricles is the AV node. Then once that electrical impulse reaches the Purkinje fibers, it stops and awaits another signal from the SA node. With AVRT, or atrioventricular re-entry tachycardia, there is an accessory pathway that leads from the ventricles back up to the atria. Once the electrical impulse reaches the atria via this accessory pathway, it causes the atria to then contract before the SA node sends another signal. That signal that wasn't supposed to be sent back up to the atria in the first place then reaches the AV node, which reaches the ventricles, causing them to contract, which means that AVRT and AVNRT can have rates as high as 200 to 300 beats per minute. So both AVRT and AVNRT are types of supra-ventricular tachycardias, which just means that the electrical impulse, the dysrhythmia, originates above the ventricles. The most common form of AVRT is called Wolff-Parkinson-White syndrome, in which the accessory pathway is called the bundle of Kent. The only difference between AVRT and AVNRT is that with AVNRT, or AV nodal re-entry tachycardia, means that the accessory pathway is located in or very near to the AV node. With both AVRT and AVNRT, the tachycardia is usually very short in duration. It is very rarely life-threatening. However, the patient may experience feelings of palpitations, shortness of breath, dizziness, and in severe cases, possibly syncope. On ECG, here's how you're going to tell the difference between AVRT and AVNRT. With AVNRT, because that accessory pathway is located near or within the AV node, the electrical impulse is going to reach the atria and the ventricles at the same time. So on ECG, your P wave is likely going to be buried within your QRS complex. With AVRT, the P wave may or may not be visible depending on where that accessory pathway is located. The medical treatment for both of these dysrhythmias is radiofrequency catheter ablation. We've got to ablate that accessory pathway. I hope this has helped. Follow for more. Go Vols.